This show is introduced to you by Global Healthy Living Foundation. The Global Healthy Living Foundation is a non-profit working to improve the quality of life for people living with chronic conditions through advocacy, education, and patient-centered research. We wish to acknowledge the Dutch people as traditional custodians of the land on which I live and work. I pay respects to the elders past, present, and future. Welcome to A Matter of Vax. This episode we meet Associate Professor Dr Anthony Byrne, a thoracic physician at St Vincent's Hospital in Sydney and a researcher at the University of New South Wales. 2 years and 3 variants of concern into the pandemic, I asked Dr Byrne, what is long COVID? Who are the most vulnerable? And with surging cases of Omicron, what's next? Finally, we find out what people with chronic diseases should be doing to manage their health and their risks right now. Associate Professor Dr Anthony Byrne is a thoracic physician with a global reputation for treatment of tuberculosis, or TB. That is until now. 2 years on, and Anthony has spent most of that time managing COVID-19 cases and is becoming an authority on patients with long COVID. Dr Byrne told The Guardian in December that he was comfortable treating drug-resistant TB, but felt scared at the outset of COVID-19. So little was known about the disease. He's learned a lot since then. We ask him all the right questions to help you manage in this health crisis. Welcome, Dr. Anthony Byrne. A lot's happened in the last 2 years. What was it like at the hospital before the pandemic?
Yeah, thank you. If I cast my mind back to 2 years ago, so I was working and still am working as a respiratory physician at St Vincent's Hospital in Sydney. It's a busy tertiary hospital. It's a referral centre for heart and lung transplantation. And I was working on the on-call roster for thoracic medicine. So we would get patients in that were unwell with respiratory problems such as pneumonia, pulmonary fibrosis, tuberculosis. I run a tuberculosis service at St Vincent's. I did 2 outpatient clinics per week with patients with infection and disease related to tuberculosis and also other mycobacterial diseases. Lots of teaching of medical students and junior medical officers, registrars, involved very much with the University of New South Wales and supervising both medical students and also honours students and research year students. So that was a busy part of what I was doing as a clinician researcher. So treating patients in hospital and out of hospital, private consulting rooms as well. 2019 was a particularly busy year for me traveling overseas. One of those overseas trips was to an inaugural symposium that I was invited to in Stellenbosch in South Africa, looking at post-tuberculosis lung disease, which is a particular interest of mine. I also spent time in the Solomon Islands. One of the other particular passions of mine is resource-limited settings and integrated care and improving lung health. We spent time there looking at the resources that were available in the Western province of the Solomon Islands, looking at lung health. St Vincent's actually had a long relationship with GIZO in the Solomon Islands and sent a junior medical officer there for many years to help staff their emergency department. I was also collaborating and still am with researchers in the United States and in India. And we were about to start a study looking at giving treatment for asthma and COPD in the southern part of India.
I can't imagine managing all of that when the pandemic began. Anthony, you said in The Guardian in December that a whopping 50% of those hospitalised and 30% of those not hospitalised were experiencing long COVID. What is long COVID and how has that changed your career?
Yeah, look, Steph, it's a great question. And long COVID has now a sort of a formal definition from the World Health Organization, but it's something like a lot of things in medicine that sort of starts out with a recognition from patients and clinicians and then researchers before it's sort of recognized. And that's what happened with long COVID. So many of your listeners will have probably remembered that early on in the pandemic, the start of 2020, there were these reports that were initially on social media of these people that had COVID They were unwell with their COVID and they just took a long time to recover, and they seemed as though they weren't recovering. I remember seeing posts of people with their hair falling out and having fatigue, and that was sort of termed long COVID, largely I think by patients that just recognised this. And it's obviously a new disease, so it's not very often in a career as a doctor that you actually come across a completely new disease, and that's what happened at the end of 2019 and for us the start of 2020. So it was then recognised in research, and I was leading one of the researchers on the ADAPT study, which is an observational cohort study at St Vincent's. And in that study, very much on the fly, we set up that study to characterise what was happening with these patients that were both admitted to hospital but largely not admitted to hospital, that suffered from acute COVID, and followed them up over 12 months afterwards. And it was recognised that a percentage of those patients had ongoing symptoms. Now, we used a definition in that study of any one of 3 symptoms that were ongoing beyond 3 months. And those symptoms that we chose were shortness of breath, chest pain, and fatigue. And they were the main 3 symptoms that we were seeing in that population. And so if you had one of those 3, then we classified you as having long COVID. We now have a formal definition from the World Health Organization that actually only came about in October of last year by something called a Delphi consensus, which is basically just a group of experts deciding on how to define this. What we do know about long COVID is it's very heterogeneous. It's quite variable. There's a bunch of different symptoms that people can suffer from, but common ones are fatigue, breathlessness, pains, chest pain, but also some curious ones like anosmia, which is when you can't smell, higher center functioning, so sort of cognitive disorders, problems of processing thoughts, thinking of words, sleep disturbance, depression, headaches, brain fog, concentration, muscle aches. There's just a bunch of them. So basically the World Health Organization said, look, if you've had either probable or confirmed SARS-CoV-2 with ongoing symptoms that last at least 2 months, and these symptoms can't be explained by some alternative diagnosis, then they call that long COVID. So that's the definition that's now formalized. And as you said, it's very common. In our population in the ADAPT study, 90% of them were not admitted to hospital. We found that 40% of our patients had these ongoing symptoms that were still present at 8 months. So they were present at 4 months, about 40%. And then by 8 months, 32% of them were still symptomatic. In earlier studies, the 50%, in fact, one study from Italy of hospitalized patients found that about 55% of patients were still symptomatic after a couple of months post-discharge. Patients that we're talking about here in our study were in their sort of mid to late 40s on average. In the Italian study, sort of late 50s. And that's very representative of the cohort of patients that we saw with the earlier variants of the virus. And another important point was that obviously this was all pre-vaccination. So that's a little bit about long COVID and who are vulnerable to long COVID. Well, we know from our study that it was almost 3 times more likely for someone to have long COVID if they were female. So that's quite an interesting finding. We also found that those small number of our patients that were hospitalized were much more likely, nearly 4 times more likely to have long COVID. And this is borne out in some of the other studies that have been published, one in Nature Medicine last year from Sudre and colleagues. They found in their population of patients that those that had more symptoms at the start of their illness, they were 3.5 times more likely to have long COVID. Increasing age was also a risk factor. They also found female sex was a risk factor, which is curious, and increased body mass index over 30. So if you're obese, female, increasing age, hospitalized, lots of symptoms, then they're all risk factors.
Some of those statistics are really surprising to me. I'm wondering, with Omicron, we hear the majority of the cases are mild, but are we really bearing the long COVID risk in that generalisation?
I think there is a risk of long COVID. There's 2 reasons to be optimistic. One is that most of the data that I've just been talking to you about is in sort of a virgin population, if you like, that are unvaccinated. And we know now that 94% of our New South Wales population is double vaxxed and 92% over 16 years in Australia. So that's going to give you protection, I'm very sure, because it protects against infection and against disease. There is some studies that have shown that there is a reduction in long COVID. There's a little bit of controversy about this, but a bit of a reduction in long COVID in those people that are vaccinated that are unlucky enough to get the infection. We certainly know that if you get the infection with Omicron has this ability to evade the vaccine and immune response more so than Delta and other variants. But you still have this protection from hospitalisation and death. And as we've just talked about, risk factors for long COVID are hospitalisation. So if you can prevent hospitalisation, then you should be less likely to get long COVID. The problem, I guess, is there's a couple of unknowns. One is that we don't yet know what the long-term effects of Omicron are because it's only been around for a bit over a month, 2 months, in fact. So we can't, using the WHO definition, we don't know anything about long COVID in anyone with Omicron. It's a milder illness, it seems, so that's reassuring. But those with mild COVID can still end up with long COVID. So there's no guarantees there at all. And more people have got Omicron. So that becomes a greater problem for public health and a greater problem for service delivery assessments because you've got a greater proportion of the population that has an infection and disease with Omicron. So even if a less percentage of people are infected, it could still be a problem. Another big concern for parents, I'm a parent, I've got 3 children, and a concern is what happens with younger children that get COVID. We are in the situation now where pretty much no one under 12 is vaccinated. And there is some preliminary data on long COVID in kids. And it does seem to be, at least with previous versions of the virus, it does seem to be much less common than adults. So we do know that kids seem to be less severely affected in the acute stage with COVID. And it also seems as though they're less likely to be affected by long COVID. I think we can be optimistic, but there's still some unanswered questions that require thought and research.
I'm wondering what happens as we progress towards winter. We're already hearing about flurona and the twindemics with flu and COVID being diagnosed together. That's a frightening idea. What are our chances here of encountering the same thing as winter comes along?
If you look at the number of influenza cases historically, I mean, around the world, it's about 3 to 5 million cases of severe cases of influenza each year. About 300,000 people die from influenza each year. But if you looked at that last year, at least in New South Wales, there was hardly any cases of influenza last year. Now, I suspect that's going to change this year. There's more people moving from the northern hemisphere winters to our summer, and that's going to sort of reverse mid-year. So there has been this case of flurona reported in the literature of someone that was unlucky enough to get both SARS-CoV-2 and influenza virus detected at the same time. I would say that's incredibly uncommon. We have a test called a multiplex PCR that we do on patients that come into St Vincent's with symptoms of respiratory viruses. We really want to know what virus it is, and we test for about 20 different viruses at the same time. And I can tell you that in the last few years, the number of patients that have had 2 viruses detected at the same time, I could count on one hand. So it almost never happens. I think it's very unlikely that you're going to get too many people getting influenza and COVID at the same time. But within a 6 to 12 months, I think, it's entirely possible that people can get the flu and COVID. And it's another point about vaccination. You know, we all have been told about vaccination for COVID, and that's incredibly important. But it's also important to vaccinate against flu. Flu is another preventable illness. And historically, a lot of people that were being vaccinated for flu were people over the age of 65 or those with chronic respiratory conditions. Interestingly, when you look at the literature on flu vaccination and prevention of mortality in over 65s, it's actually not as strong as what you'd think it would be. The interesting thing about that is that there's some unpublished data that I've just finished some research on, and it appears as though there's a long-term mortality risk in people that have had influenza. And a lot of those people are young people. So even if you don't end up in hospital with the flu, you probably actually have an increased mortality. I think it'd be really interesting to do a study looking at influenza vaccination to prevent mortality.
Mm.
There's a really strong case for getting everyone vaccinated against the flu this year, in particular, given the twin insults of COVID and influenza that are upon us. I would also like to mention tuberculosis. So when we talk about global pandemics, COVID is a really important global pandemic that's killed millions of people. But tuberculosis is actually also a global pandemic. And up until COVID came along, it was the number one cause of death from an infectious disease, with 1.5 million people dying from TB. And last year was the first time that TB deaths actually increased for the first time in 20 years. TB is the second most common cause of death behind COVID. So globally, TB is actually the second most important pandemic. And it's a lot harder to diagnose. It's a lot harder to treat. It takes months of treatment. And in a lot of the countries that are terribly affected by COVID, in Africa, Latin America, and Asia, they have this twin burden of disease, in fact, with tuberculosis. And you can imagine what would have happened to their health systems in the last 2 years. And if you've got TB and you're sitting at home, being infectious to others, and lung function is deteriorating, and then finally you get a diagnosis, if you're lucky, that's happening a lot around the world.
I think tuberculosis is one of those diseases that we think of as being in medically underserved environments and in developing communities, and we don't think of it as being in our backyard, but it most certainly is. Australia has TB cases every year.
It absolutely is. And I think what COVID does for us, there's a bit of talk about this recently. I mean, the reason we have these variants, the reason that Omicron came along, if we have these infectious diseases, until we eradicate them everywhere, they're going to be a problem for us, for years to come. So we have to really be coordinated and have access to healthcare and access to vaccines in lots of settings. It's been really amazing to me in the last 18 months, 2 years, that we've been able to get these amazing treatments, these amazing vaccines for COVID. It's really amazing that this has happened. We've been trying to do this for TB for a long time. And unfortunately, it speaks to the fact that COVID affects Europe and North America, and TB largely doesn't so much, at least not in the way that people see.
Mm-hmm.
I think that gives me hope that if humanity comes together, we can actually solve a lot of problems really quickly, in fact. So that makes me optimistic, I think, for the future.
When I think about Omicron, I think about the chronic disease folks out there and how they're preparing for Omicron, how they're coping if they've already got a positive. What's your advice to them now?
Oh, look, Steph, that's a really great question. What I'd say to people is that you need a plan. Everyone needs a plan. Talk about a fire plan. If you live in a fire-prone area, you need a chronic disease management plan. So I would say if you've got a chronic disease, you're immunocompromised, or you're elderly, you need to be, number one, vaccinated like 3 times if you can. You need to have a chronic disease management plan with your GP and your specialist. If you don't have a specialist and you've got a number of complex conditions, get one. You need to know when and how you should seek care. We're lucky now that we've got telephone consultations. You can get on the phone to your GP or specialist. Some of them will bulk bill that. And so there's really no excuse, but it's not a replacement for potentially getting in and being evaluated, because it's really hard to listen to someone's chest or measure their lung function over the phone. Like, you obviously can't do that. And I would just urge people not to delay really important stuff. That's a really big problem. If you do get COVID despite doing all the right things and being vaccinated, then, you need to have some sort of a plan. And I was listening to Claire Skinner, who's president of the Australasian Society of Emergency Medicine, and she was talking about having a COVID management plan for people at home. So what I would say is, if you've got symptoms or you're close contact, if you've got a diagnosis, you've got to self-isolate for 7 days. If you're over 55 years, or if you've got some complex chronic respiratory or chronic medical problems, we can actually, if we get you early enough, we can give you an injection of a medication to keep you out of hospital, a monoclonal called sotrovimab. It's a bit hard to get and give, but we can certainly do it. So, if you're sort of partially vaccinated and you've got those things, get in touch with a hospital so that we can do that for you. And a lot of GPs and other people don't actually know, but you can actually give inhaled steroids via prescription medication called budesonide, trade name with another medication called Symbicort. That was actually given as part of a clinical trial for people over the age of 18 that had symptoms within the first week of those symptoms coming on. And it was shown to reduce the rate of hospitalisation. And that's just taking a puffer 2 times a day. So it's really simple. And I haven't heard anyone talking about that. But, that's something that a GP could potentially prescribe to someone with respiratory symptoms that had a positive diagnosis of COVID. So these are some simple things that could be done to treat COVID at home. And it's important to have a plan. You've got to be prepared.
I think there's an opportunity here for us to all redouble our efforts in prevention. So all of the usual hand sanitizing and distancing, but most importantly, if you've got a chronic condition at the moment, you need to take care.
I think that's really good advice. And what I try and say to a lot of the patients that are healthcare workers that I have is, get a GP. Get your own GP. I mean, a lot of the things that GP can do really well is preventative medicine. And in order to do that, you've got to have one. So a lot of healthcare professionals are guilty of not having their own GP. So, I think it's a good message to get one. And then you do have that, where to go and how to contact them.
Anthony, thanks for joining us today and for all of your time.
No, you're most welcome. Thanks. Thanks to you for inviting me, and hopefully it was useful for you and your listeners.
Talking about vaccination and your health can be a difficult conversation. Our hope is to make it easier for you to understand and communicate these important subjects to your community. Please share this podcast with friends and family and subscribe wherever you listen to your podcast to hear more of Matter of Vax. To learn more, please visit our website ghlf.org.au for vaccination facts, video explainers and patient stories from all over Australia. And be sure to subscribe to our news and community support from GHLF. I'm Steph O'Connell for Global Healthy Living Foundation, and this is Matter of Vax.